Yep, another Puscast. This one covering the first 15 days of April 2016 with nary a April Fool's joke to be found. This podcast is brought to you by Pusware LLC, my growing multimedia empire that can be found over at edgydoc.com, as well as links and references. Otherwise, nothing exciting to tell you except to go to iTunes and write me glowing reviews. Yeah, you know you've been waiting to do it and you keep putting it off. Now's the time. Otherwise, we are going to move on to the literature. Infections are bad for you. We all know that. Well, they're good for me when you get an infection. But the epiphenomenon that occur after infections are also important. I have rambled on at length about the increased risk of vascular events after infections, but they can do more than that. There's been this long issue as to whether or not schizophrenia can be set off by infections. And a variety of infections have been associated with schizophrenia over the years. Now there comes an epidemiologic study out of Denmark where they looked at the subsequent diagnosis of schizophrenia or a mood disorder after an infectious disease. They used a prescription for an antibiotic as a surrogate, so I don't know if they may or may not have underestimated the number of viral infections that occurred. But the more infections you had, the greater the chance of having schizophrenia with an odds ratio of 1.37 or a mood disorder with an odds ratio of 1.64. So the inflammation that occurs as a consequence of infection may be bad for the brain. And I find this particularly interesting because there's the slightest of hints that the vaccine schedule protects from neurodamage, including autism, rather than causes autism, as such world-renowned experts as Robert De Niro think. Gag, puke, vomit. Certainly, infections can be both directly and perhaps indirectly neurodamaging. And if you can avoid the infections, maybe you can avoid the neurotoxicities. Infectious diseases is nothing if not applied evolution. There is this way cool project called the Michigan State University's Long-Term Evolution Experiment. Since 1988, they have been passaging E. coli in the same media year after year after year and seeing what happens. They have 40, 50, even 60,000 generations of growth of this one clone of E. coli, and these E. coli have been grown in identical media since 1988. Now, generally speaking, evolution is thought to occur in response to the environment, that you have mutations and that fitness is selected for by the environment, favoring or disfavoring some genes. That's some basics for you who are educated in Kansas. It turns out that even in an identical environment, as happened in this particular long-term trial, the E. coli continued to evolve, albeit in different ways in different populations, in response to the environment to become increasingly fit, as measured by multiplication times. So even in the absence of a environmental stress, these E. coli's all continue to evolve towards better fitness, although each of the tested populations did it in a slightly different way. So if you extrapolate from that, you can figure that these organisms that we deal with as pathogens are probably evolving slowly to kill us no matter what we do, antibiotics or otherwise. But it's a fascinating long-term study. The Zika virus, of course, is the new worrisome virus, although you should still worry about dengue and yellow fever and chikungunya. In fact, you should be panicking about all infectious diseases. The worst thing about Zika virus is that it causes microcephaly in utero, and it can be an STD, as it were. There's been documented spread from males to females, and if they were pregnant, you could then cause problems in the baby. The CDC has a recent report of sexually transmitted Zika virus male to male, so it can be spread that way. The good news is you're unlikely to put a fetus at risk with that kind of transmission. However, it's important to remember that this virus is associated not only with Guillain-Barré syndrome, how's that for a French accent, but also acute disseminated encephalomyelitis. So it can cause at least 2 other neurologic syndromes in addition to microcephaly in the fetus. So keep it in mind for those occasional Guillain-Barrés or ADEMs that come through your hospital. This is April, and flu season in the United States appears to be winding down. This study out of France looked at the risks for a bad outcome from influenza, and they found being old and having comorbid conditions was associated with a poor outcome. No surprise here. But here's the thing I keep harping on. Quote, vaccination and early oseltamivir administration appear to reduce ICU admissions. So you may still get the flu if you get the vaccine, but you're less likely to end up in the ICU, especially if you're elderly with a comorbid condition. Older people, like me, don't respond to the flu vaccine like they should. And it's always been assumed it's because, well, they're old. But most old people are on statins. Everyone's on statins. Everyone should be on statins. Statins are the wonder drug that works wonders, right? I don't know. Probably that's aspirin. But there are 2 interesting studies in clinical infectious diseases this month. First, they look at patients who had a medically attended acute respiratory illness. Okay, that can be flu, that can be other things. And they found that people who had the flu vaccine were more likely to have a medically attended acute respiratory illness, suggesting that maybe statins were attenuating the influenza vaccine efficacy. Unfortunately, all that glitters is not gold, and all that is an acute respiratory illness is not influenza. But in the same CID issue, they looked at the antibody response in patients who had the flu vaccine, whether or not they were on statins, and found that if elderly were on statins, they had a decreased response to both regular and flu vaccine with adjuvants. The antibody levels were 38% lower. So there is now a suggestion that people on statins get less efficacy from influenza vaccination. So now we need to prove that in trials to look at the real deal. Do patients on statins and who get the flu vaccine truly have more or worser influenza? And then you'd have to suggest that perhaps people need to have their statins held during their vaccination period. And if so, starting when and ending when. So there's some real questions to be answered in the effect of statins on influenza. But at least this preliminary evidence suggests that part of the reason why the elderly don't respond is they are immunosuppressed from their statins. And the problem is, of course, influenza is not simple. Vaccination is effective, but how effective it is depends on the population vaccinated and the circulating strains. This study looking at the efficacy of H1N1 vaccination in a pediatric population and households found it to be very effective, 66% for H1N1. But the other interesting thing about this study is there was a lack of negative effect from repeated vaccinations. It was suggested last year that multiple vaccinations for influenza actually decreased the efficacy of the vaccine. That may be for H3N2 strains, but for H1N1, repeat vaccination did not decrease your chance of protection. So again, the problem with flu vaccination, unlike, say, tetanus, is that it's complicated. I'm about to speak gibberish as if I know what I'm talking about. There's evidently the signal transducer and activator of transcription 1, STAT1, gain of function, GOF mutation. The GOF STAT1 mutation is associated with chronic mucocutaneous candidiasis, autoimmunity, enteropathy, an X-linked like syndrome, and now PML. I remember the stat 1 in reference to an article in the New England Journal about chronic mucocutaneous candidiasis, and it seems to be the predominant defect that they have diagnosed in these patients. But these patients with the stat 1 gain of function mutation are also at increased risk of PML. That I've said it, I may remember it, maybe I'll recognize it on my boards, maybe this will go in one ear and out the other. But if I see another case of PML in the future outside of a transplant patient or an AIDS patient, I'm probably going to remember to go Google other reasons people get PML. Sometimes I think my only role as an infectious disease consultant is to look up all the crap no one else wants to bother doing. I always think of it as the Will Rogers infection. Evidently, he never met a pneumovirus he didn't like. One of the nice things about these broad-spectrum PCRs is we're seeing all these metapneumovirus infections. So what, you may ask, is the metapneumovirus season? We now know. Yay! It lasts from winter until spring. It tends to occur at the same time as the RSV and influenza season, but it peaks after these two infections. So it tends to be concomitant with the RSV influenza season. There's a study a couple of years ago that showed that the RSV season in England is shrinking with global warming. So who knows, maybe the metapneumovirus season, it will be shrinking as well as the world gets warmer. And I think that's a good trade-off. Less RSV, less metapneumovirus, more chikungunya, more malaria, more Zika, more dengue, more leishmaniasis, more of everything. Except these damn respiratory infections. The one I have just keeps going on and on and on, and I'm sick of it. Whiny old man. Wah. About a decade ago, Rickettsia moved into Arizona. I think, as I remember from the New England Journal report, it was associated with dogs that brought it into that area. But the range of Rickettsia, Rocky Mountain spotted fever, had spread to the Arizona area. Now it looks like Rickettsia parkeri is there as well, both, of course, spread by the amblyomma ticks. Ugh. Although in this report, they do wonder if some of the cases of Rocky Mountain spotted fever were actually Rickettsia parkeri. Arizona has all the fun stuff. Cocci, Hanta, Rocky Mountain spotted fever, plague. Why wouldn't you want to live in Arizona? I mean, there's virtually nothing in Oregon except a little collection of relapsing fever in the eastern part of the state. Otherwise, for infectious diseases, Oregon is dull as dirt. A little bit of Staph aureus stuff. Staph aureus actually is a complex. I have a complex about Staph aureus, but there are two other very closely related staphylococcal species that are similar to Staph aureus. One is called Staphylococcus argenteus, and there's a non-human primate-associated Staphylococcus schweitzeri, schweitzeri. These are all very phenotypically similar to the Staph aureus we all know and hate and causes human disease occasionally. For example, in 1,903 isolates of Staph aureus, 3 were actually Staph argenteus. And I need to ask on Monday if our MALDI-TOF will differentiate between Staph aureus and Staph argenteus. I should have figured if TB was a complex, why not Staph aureus? Just remember, if your patient has atopic dermatitis, they're highly likely to have Staph aureus colonization as well compared to normals. The odds ratio is 19.74 in this meta-analysis. But generally speaking, patients who have any kind of chronic dermatitis, psoriasis, eczema, atopic dermatitis, who have active disease, they are carrying staph both on the lesions and in their nose. And the worse the disease, the more likely they are to be carrying staph. That's important if you're a surgeon sticking an artificial hip into somebody, for example. And most of my surgeons seem to be unaware of this. And finally, when I was an intern, yeah, I'm that old, I had a patient admitted in the field who had a line placed after a syncopal episode. It was a peripheral IV that got infected and caused septic thrombophlebitis that went to her aortic valve, which blew it out and killed her in about 3 days. I've always found that to be a very impressive complication of what should have been a trivial IV placed in the field. This study looks at how often intravenous catheter is a source of Staph aureus bloodstream infections, and they found a pretty high rate, 7.6%. 34 of 445 patients with their staph bacteremia had it due to the peripheral IV. And the key thing, which I've been saying for years to house staff, it's nice to see it validated in a study. It's not the current IV site, it's the old IV sites that have the septic thrombophlebitis that lead to bacteremia. This study was out of New York City, so I wonder if it had anything to do with New York values. They value their staph bacteremias in New York. The pattern you sometimes see with patients with acute cellulitis, diffuse erythroderma of the leg, is they get a chill and a fever and groin pain. They take to their beds, and when they wake up, their leg is all red, hot, and swollen. But note the groin pain. I've always figured that that was local lymphadenitis that was causing inflammation and pain. I like to refer to it as Crislip sign. Yes, I'm that modest. But here's an article which I find really cool. I'm just going to quote the abstract. It was a presentation, so I don't have the full reference. But, quote, the potential for extracellular bacteria to access this system, the lymphatic system, has been largely ignored as an accidental consequence of normal interstitial fluid transport. Group A streptococcus, a virulent human pathogen that is known for its capacity to disseminate systemically, can rapidly access the lymphatic system and local lymph nodes via a hitherto unrecognized but specific interaction between its hyaluronin capsule and the lymphatic endothelial receptor LYVE1. The consequences of this for the infectious pathogenesis and immunity are emerging areas of research that are important not only for streptococci, but for other major bacterial pathogens, and confirms the pathophysiology of Crislip sign. I tell you, you got to get in the medical literature under my name. Someone needs to do a study proving that clinical observation for me. Because I tell you, the local lymph node inflammation preceding the erythroderma is not described anywhere I can find. I'm too busy blathering away with this kind of stuff to do the retrospective clinical trial, but some future ID doctor needs to investigate this and name it after me. I am the discoverer. Crislip sign. Inguinal lymph node tenderness preceding the erythroderma of lower extremity cellulitis due to group A streptococcus. I feel almost completely vindicated. I'm kind of sort of the opinion that if you can do susceptibilities in MICs, you should do susceptibilities in MICs. That's not always easy. For example, with Cryptococcus, they recently had a study that looked at outcomes, and they did not find increased mortality in patients with higher MICs, but they did find that those who had higher doses of fluconazole, 800 milligrams a day, or voriconazole, which has lower MICs against Cryptococcus, had better outcomes. Generally speaking, we need to always think pharmacokinetically in ID, and if the MICs are up, you should probably push the drugs up as well so that you always maintain therapeutic levels. Just like there are Staph aureus as a group of organisms and tuberculosis as a group of organisms, so unfortunately is Cryptococcus. There's always been Cryptococcus neoformans, and then we had Cryptococcus gattii from New Zealand and the Great Pacific Northwest, and there's Cryptococcus grubii found in Southeast Asia, and now in Zimbabwe, it's Cryptococcus tetragattii. I assume it's 4 times worse than gattii, but the majority of cryptococcal meningitis in HIV patients in that part of the world were due to Cryptococcus tetragattii. There's probably, I bet, even more cryptococcal species out there that infect humans, and that wherever you have geographic isolation of Cryptococcus, they may look the same, but they're probably different. Again, evolution in action. Just like the cocci in South America is not the same as the cocci in North America. And the histo in the Caribbean is probably not the same histo that's in North America, and is certainly not the same histo that is found in sub-Saharan Africa. Separated organisms evolve differently. We talked about that about E. coli earlier, didn't we? I guess that's the theme of today's podcast, or Puscast. Generally speaking, when I ask house staff how patients get toxoplasmosis, they normally say cats, which is not true. It's diet. Well, it's not true unless you happen to eat cats, and cats are usually best done rare to medium rare. It's the other white meat. But actually, you get toxo from eating undercooked meat. That is the usual source in most of the world, except if you drink camel's milk. In eastern Sudan, 100% of people are toxoplasma positive and is likely from drinking the raw camel's milk. They took camel's milk, they fed it to itty bitty little kittens, and all the little kittens got toxo. Kind of an awful way to do a study in some way. You know, you take camel's milk, you feed them to kittens, and you see if they get toxo. Oh well, that's science. So, pasteurize your camel's milk, I suppose, is the take-home message. And as long as we're on the topic of new organisms, which seems to be the problem, you have trypanosomiasis, right? There is the sleeping sickness trypanosoma of Africa. There is the Trypanosoma cruzi, Chagas disease, found in South America. And now there's a new trypanosome found in Southeast Asia. It's Evansi, Evansi. Hi, we're going to give a new organism to you, and we're not going to give a pronunciation guide. They have to do pronunciation guides. But this is first diagnosed in a patient who was butchering raw beef and came down by way of the wound with Trypanosoma evansi. And they subsequently looked and they found it was widespread in the cattle. So now we have trypanosome in Africa, trypanosome in South America, and trypanosomes in Asia. Living in the Great Pacific Northwest, I don't see a lot of malaria. Maybe a case every couple of years that get into the state in some traveler. Interestingly, there was a study that showed that chloroquine resistance is dose dependent and that you can still take care of resistant Plasmodium malaria by giving high dose chloroquine. The other interesting thing about malaria, and I did not know this, that asymptomatic malaria is common where there's a lot of transmission. This review says, or this article says, that everyone in those areas are infected with asymptomatic malaria. They also have long thought, evidently, and I did not know this either, that in areas where there's low seasonal transmission, that most people don't have asymptomatic malaria. But they went to Southeast Asia, Thailand, Cambodia, Laos, Vietnam, and used PCR to see how many people were positive for malaria. And it turned out 27.5% of people tested were positive for either Vivax or falciparum by PCR. So asymptomatic malaria was common in these malaria endemic areas, although the organisms were small in number. Keep them away from Pacific Northwest mosquitoes if they happen to come visit my part of the world. But that represents one hell of a reservoir for malaria. Well, I suppose I'll bring it to a close here. I don't have anything else in particular I want to talk about, except to mention that at the start of the season, my wife and I thought the Blazers would go 41-41 and make the 8th seed in the playoffs. We're now the 5th seed. Did even better than I predicted. So I predict now that we're going to take the Clippers in 7. Otherwise, I'm going to bring this podcast, this Puscast, to a close. The references are available at edgydoc.com. You can find links there to my growing multimedia empire, including the 2 books I have published that make great Christmas and birthday presents. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. Thank you. In dictation. Goodbye. Go Blazers.